Thank you, Peter, and welcome everyone to King's and this event. The RfPB programme is one of about half a dozen programmes run by NIHR, science programmes run by NIHR, including things like the Health Technology Assessments programme and the Public Health Research programme. There's a number of programmes, all of them have directors, and we all get together regularly to make sure we coordinate our different programmes together. So we see ourselves as sort of offering a seamless service. An RfPB across all these programmes is the small grants, relatively small grants programme compared with the others. And so we see applications from lots of different areas which will perhaps in turn, as they develop further, go into the other programmes. So we try and coordinate that shift. We're a response mode funding programme, which means we're open to any ideas that people have got. We don't stipulate what those ideas would be. We don't commission research. We do occasionally join with all the other programmes in having themed calls. So the current themed call, for example, is on research on obesity. So all the programmes are sharing this common theme, saying we will give some strategic uplift to applications which consider obesity. Our grants are small grants in medical standards, not by anyone else's standards, and we give grants up to £350,000 for up to 3 years of research. We run 3 funding competitions a year, and we are regionally based. That is, the actual decisions on which applications to fund are made by a regional panel, and you'll hear the chair of our local regional panel in London shortly. But you can see there the map of the country, or you can't see very well, but there used to be 10 regions, and we're now down to 8 regions in the country. And by and large, we try and take the applications to go to that region to be assessed, though sometimes because of conflicts of interest and so on, we actually have to put them into other regions. But we remain essentially a regional-based programme with all these different regional panels making the actual decisions. Part of my job as director of the programme is to take a strategic overview of what's going on. So I travel around, I sit in on the panel discussions, I talk to different people, I talk to applicants, I talk to successful and failed applicants, and I talk to panel members. And what are the things that people say is wrong with RfPB? And the sorts of things I've picked up over the last few years, people say it's a bit bureaucratic, all those panels. It takes a long time to get a decision out of them. It's not very kind to new investigators, it seems. I don't think that's right, but sometimes people say, well, if you're a new investigator, you've never held a grant before, how are you going to get a fair hearing from RfPB? People say it's a lot of work for just £350,000, and the argument there is based on the fact that all the programmes use the same standard application form. So they all use the same form, they should be familiar. If you apply to HTA, you apply to the Public Health Research Programme, you're basically using the same form. But if you apply to HTA, you use the form to ask for trial for £2 million. If you come to RfPB, you do exactly the same amount of work just to ask for 350 maximum. So a lot of people say, that's a lot of work for that amount of money when I could go to one of the other programmes and get oodles more cash. Maybe. It also can seem capricious in its judgments and feedback, and I guess being a research applicant myself at times, I often wonder how any panel can possibly turn down my superb research, but they do. And sometimes it doesn't seem to make sense. Sometimes they turn down research and it doesn't seem to make sense. And I'm sure all of you who've had rejected applications will know that feeling. You think, why did the panel make that decision? We try and give feedback, but still sometimes those decisions don't seem very coherent. It gets a lot of similar applications. When I sit and look at all the panels and see the applications coming through, I see a lot of similarities across these applications. And finally, a common theme that's, I think, recurring across all the NIHR programmes is we don't seem to always engage with the NHS. The NIHR is the research arm of the NHS, and we should be seen as the research arm of the NHS, but I think often we're seen as somehow separate. We've been sort of got by the academics who are running us and using us as a resource instead of being tied in with the NHS. And so again, that's a perennial problem. Now, given all these issues that have emerged, and I'm very aware of, that have occurred over the last few years, and indeed since the programme's inception, then we're trying to do things to address them all. And you'll hear later on today how we're addressing some of these with this new process for giving an application to RfPB, particularly the one around the lot of work for just 350k, and also to do with the judgments. But you'll hear more of that in a moment. But what I want to do in my brief 10 minutes I've been allocated is to look at this issue of similar applications. Because again, travelling around, I think I've heard that application before, or a very similar application, and when I go back and look at it, there are some patterns there. And what I've managed to devise from these patterns is 2 devices for doing research. Now, these are the things that I think are out there, that people are doing it, and the first one is the research one-arm bandit. I'm calling the research one-arm bandit. And what you do is you pick an intervention, and I've just picked some of the common themes here, like CBT, CBT variants, and exercise are very common examples of this. There are, of course, others. And what you do is you take from each of these red boxes, you take one of these themes, and you say, is CBT effective in treating heart disease in old people in Manchester? Yeah? Instant research question. Off you go. Or you say, is exercise effective in treating depression in young women? Yeah? Off you go. Now, it seems to me that this machine, this one-arm bandit, you just keep pulling it, and you just keep doing all these research questions, and ultimately they get rather repetitive, because a lot of those themes are already being covered. If it works in Manchester, why shouldn't it also work in London? If it works in ethnic minorities, is there a good reason why it shouldn't work in non-ethnic minority populations? So very often people are using this one-arm bandit just to juggle around the different populations or the indications or the type of intervention. And it seems to me that we need something more innovative than this, because very often we sort of know the answer to these questions because, as I'll show you in a minute, things like exercise has been shown to be effective in lots and lots of circumstances. So do we need yet another study showing the same? So the first thing I recognise is these research one-arm bandits, and I would urge you to depart from this machine for creating research. The second model I detect out there, which again causes me to pull my hair out, is the inductive, I haven't got a lot to pull out, have I? Is the inductive, what I call the inductive research machine. And here's an example of it, a caricature of this sort of model. Somebody says, I want to devise a new intervention to tackle obesity. Big problem, theme call, why don't we have a new intervention to tackle obesity? So what they will propose to do is to do qualitative interviews with obese patients to identify the barriers to losing weight. Yeah, let's talk to lots of obese patients. Let's talk to a lot of people with this problem and say, what is the solution to your problem? And then from this, we will construct an intervention. Not clear exactly how, but they will analyse the data they get, and somehow out of this will emerge this brilliant, innovative, effective intervention. And then they might use some consensus methods to agree what the final intervention might look like. Now, this might come off. In this particular instance, I doubt if it would. But there may be instances where it might come off. But this seems to me to be a high-risk proposal for the programme. What are the chances that a research proposal like this will come up with anything innovative that's going to be effective, that's going to make any impact on the obesity epidemic we have? So to my mind, a lot of these inductive research machine things we churn out of this form are very high risk. I'm not saying that they're all out of scope, but somehow a lot of them are high risk, and therefore panels are unlikely to say, wowee, this is a great idea, we can see this trajectory into patient benefit, and it's going to really improve patients' welfare. So it seems to me for many questions we sort of already know the answer. Those of you who are Bayesians in the audience will know that a lot of the ideas we have, we've already formed these prejudices, these priors about what will work and what won't work. So, does exercise benefit a specific disease? We can go on adding all those diseases, but every time we do an exercise study, we find it is a benefit. Almost in every disease you can think about, is most probably yes, it seems to benefit most diseases. But therefore, the interesting research question is not yet another study looking at does exercise benefit another disease nobody's ever thought of, but how do we get patients to adhere to exercise interventions? That's the big problem. We know that exercise is very good for you, but how do we get people to take it up, to follow it, to adhere to exercise, to get those health benefits? That's the big question we need to answer, not whether it's beneficial for Hashimoto's thyrotoxicosis. I'm sure it is. And finally, are there diseases where exercise is contraindicated? It seems to me that's the sort of question we should be asking, given that exercise seems to affect most things positively. Are there diseases where it is contraindicated? That would seem an interesting question. So I just would urge you to be innovative and original in the applications, giving you a greater chance of success. So what is an interesting, important question for RfPB? First of all, how important is the new knowledge for achieving patient benefit? As I've said, another study looking at exercise in a group of patients in whom it hasn't been studied so far could be of value, but I won't put a lot of value on it in terms of awarding a grant and saying, this is worth £350,000. No, it's probably worth £25,000. You know, it's the balance between what's that information worth and what we're going to pay for it. What is the trajectory from this question to patient benefit? So I don't want to know about how you devise an intervention. What we need in the programme is to know how that intervention will then proceed through the various research steps so it can get into patient benefit. You don't stop just devising the intervention. It's then got to go on along the trajectory, or at least that trajectory's got to be drawn out for the panel to understand. Will the methods provide a clear answer to the question? One of the main reasons for rejecting applications is because the methods will not enable the question to be answered clearly. And finally, is the cost of the research commensurate to the risk it won't deliver? Remember, a lot of the research we fund, we expect it to have negative results, but is it worth getting those negative results in terms of the money we invest? So we invest money in devising a new intervention, and that new intervention, they don't manage to create that new intervention. How much money are we willing to risk on not achieving the aim? And so again, it's got to be commensurate. If it's high risk, it's got to be lower cost. And if it looks like, for example, a good trial is going to come and benefit patients, whether it's positive or negative, well, that can go up to the full 350k. But we'll hear more of that from my colleagues on the rest of this programme. And I think I now hand over to Richard Watt.